It is around 40%, so it can be used less reliably for the intraoperative cardiac monitoring. Transdisciplinary is coming as a new technique, and it's very reliable in measuring the cardiac output. Apart from that, it also gives additional information like the structural abnormalities and aortic pathology. It has been shown to be a good agreement with the pulmonary catheter when it compares with the pulmonary catheter, and it's useful, especially useful in patients who are hemodynamically unstable. One of the studies have shown that if the pulmonary artery catheter is in place or available in the hospital, people are less likely to use echocardiography because, again, it requires some kind of intervention, then put in the T and do the monitoring, whereas pulmonary artery catheter can be continuously monitored without any interruption. So people are more inclined toward using pulmonary artery catheter is available in the OR in the ICU. So if we look at the advantages of T, it's basically there is a large amount of hemodynamic information is available. Disadvantage mainly is it's very expensive and bulky machines. Skilled operator is required. Pharyngeal anesthesia sedation or sedation is required to let the probe, and probe is generate heats, so you cannot put it for a very long time in a patient. So next is the pulse wave analysis to estimate the cardiac output, and it can be minimally invasive or it can be non-invasive. So basically it measures the area under the curve of the arterial waveform and gives the stroke volume, and in turn that it gives a cardiac output. With that, we can also measure the stroke volume variation and plus pressure variation, which gives an idea of how to manage the fluid therapy. So if we look at the classification of these techniques, it can be divided into invasive, minimally invasive, and non-invasive. Mainly invasive is the transpulmonary indicator dilution technique, which I have already discussed. And then the minimally invasive can be divided into internally calibrated devices or uncalibrated devices. And basically, the principle of these is to measure the arterial waveform and then use some kind of software to measure the area under the curve. So depending on the invasiveness, again, as the literature supported, it can be used in high-risk complicated surgeries in high-risk patient, and then minimally invasive techniques can be used in high-risk patient in which goal-directed field therapy is required. Non-invasive internally calibrated devices can be used in low or intermediate high-risk surgeries, especially when there is a larger fluid shift. So transpulmonary technique is coming in, and basically it, apart from cardiac output, it also gives other information that I've discussed earlier, that it gives stroke volume variation, pulse pressure variation, status of the preload, edema, and capillary leak. And based on that, it guides you to use the fluid therapy, vasopressors or inotropes. This is one of the technique which is called LITCO technique, in which the lithium is injected to the existing central line, and we use the arterial line to actually where it sends and gives the cardiac output. So this is basically comes under the heading of minimally invasive. So all of these techniques which measures the arterial pressure and gives the cardiac output, basically what they do is that they convert the cardiac output by using some kind of specialized property algorithms and measure the area under the curve using different techniques. For example, the flow track uses the samples data point from the arterial waveforms. Then the PICO system use the excuse me. The PICO system uses starting point is the area under the systolic pressure of the arterial waveform. Here it measures the area under the systolic waveform, and the LITCO system converts the arterial waveform into the standardized volume waveform that is analyzed as a sine wave, also known as a pulse power analysis. So basically, the end point is that they measure the area under the curve and gives the cardiac output. So what is the clinical application of these devices? The decision to use or not to use of certain pulse wave analysis is individual patient or clinical setting and depend on the invasiveness, measurement performance, clinical applicability, signal stability of the pulse wave analysis system, and the availability and the cost and personal experience with the monitoring system. So all pulse wave systems investigated against the gold standard pulmonary catheter or transpulmonary dilution techniques. And mostly studies are highly heterogeneous regarding their study design, patient population or clinical setting. And although these studies are showing clinical interchangeability between the pulse wave analysis, drive cardiac output measurements, and the reference integrated dilution cardiac output measurement, but overall pool results shows that the cardiac output measurement by either methods are not interchangeable. Again, this was the meta-analysis shows the accuracy and the precision of these pulse contour techniques, and it's around 40%. So it can be used more or less reliably in these clinical settings. So next is the non-invasive pulse contour technique. In this, a simple SpO2 probe-like probe is placed on the finger and actually gives measures the signals using the infrared LED light and intermittently, like a blood pressure cuff, obstruct the blood flow in the finger and measures the cardiac output. And it gives almost the same arterial waveform as like the arterial waveform, and apart from that, it also gives the cardiac output. So these devices are totally non-invasive and gives the same arterial pressure like the arterial waveform and also gives the cardiac output. So if you look at the literature again, there is a lot of variation in terms of mean percentage error from 24 to 58. And overall conclusion is that it can be used in patient in which there is normal sinus rhythm, patient peripheral circulation is okay, and the patient are not on higher inotropes. These devices can be used reliably. So the next technique is thoracic bioimpedance and bioreactance. This basically technique uses a placement of the electrode on the chest, on either side of the chest or at the carotid artery and the side of the axilla. And what they do is basically they estimate the cardiac output by using the thoracic electrode that records the amplitude and the frequency of alternating current applied across the chest. So bioimpedance measures the changes in the amplitude, and the bioreactance measures the phase shifts. So advantage is that it's less likely that it's affected by the electrocautery. And if the signals are for 20 seconds, you get the signals, you can get the cardiac output. Major disadvantage is that motion artifact, electrical interference, arrhythmias, and mechanical ventilation. And it can give RNS reading in patients who are obese if there is pleural effusion or if there is pulmonary edema. Different devices available in the market. So when compared with pulmonary catheters, it showed good correlation as well as with the PICO and LED shows comparable results. However, meta-analysis was done and basically shows that it's not a good device to be used because it gives a mean percentage error of 42 to 48% and shows the reliability is less when you're using intraoperatively. So if we look at all these devices that I've mentioned, the main point of contention is whether less invasive is less accurate or should we go for more invasive. So indeed, less invasive needs simply imply less accurate, but with these trending abilities in these non-invasive devices, because this gives you an idea of the intervention, how it is going. For example, if you're using fluid or you're getting vasovagal inotropes, it gives you an idea whether you are getting the right result or not. So in the preoperative setting, pulse contour analysis based monitoring can be indicated to apply goal-targeted fluid therapy and gives a good result. Overall outcome results are very good. So at one end, we have invasiveness and the accuracy, basically pulmonary catheter falls here. If we have a less invasive device, which is accurate, that is the best. But again, most of the devices falls here because they are less invasive or less accurate in terms of when we look at the literature. So technically, in high-risk patient with complicated surgeries and high-risk patient, we have to go for the pulmonary catheter or transpulmonization technique or some kind of invasive technique. In between is the esophageal Doppler and the arterial catheter techniques. And in low or medium risk patient, we can use non-invasive techniques. My last point last part of the slide is basically the cost effectiveness, and that is actually very important when we are practicing in the private setup. So if we look at the cost of these devices, it's quite expensive. All of these devices is more or less same, but they're expensive, and the cost of initial setup is also like around 500. This study was done in Europe, so it's in the euros. So it was like around 480 euros and 308. And then they compare the overall implication of these devices in terms of cost of the device, cost of the initial setup, cost per measurement, and cost per day. So if we look at these devices, Pico, Litco, Nico, Hemosonic, and PAC, the initial device price is almost same. The initial device setup with the PAC is more as compared to other devices, but afterwards the daily measurement and cost per day is less with pulmonary artery catheter measurements. So basically, the Swan Guns catheter remains the clinical standard of cardiac output monitoring. Several minimally invasive and non-invasive cardiac output devices are available. Knowing the basic measurement principle of these new devices monitoring system is important to understand their inherent limitation regarding the measurement performance and the clinical availability. So what what we are basically looking for, we are looking for a device which basically help us to monitor the cardiac output. And all the monitoring options should be available on the same device. So recently, Edward has launched this Hemosphere, in which basically you have the sensor, you have like the sensor available to monitor the cerebral pulse oximetry. Then there is a cuff HPI thing which we can monitor the cardiac output non-invasively. And then we have sensors to monitor the cardiac output and the blood pressure using the existing arterial line. And then we have Swan Guns catheter, PAC catheters module available within the same device. So this is the non-invasive method of measuring the cardiac output. Simply putting the probe on the finger and a cuff at the wrist will give you the cardiac output and the blood pressure monitoring. This is the flow track system, which basically which is connected to the existing arterial line and gives you the cardiac output, stroke volume variation, SVR, and mean arterial pressure with the existing device. Swan Guns catheter, again, the module is connected to the device and gives you all the information with the pulmonary artery catheter. And this is the basically parameter that you can get with different devices with the same monitor. So now the question is, what should be the management strategy? When we are talking about going for invasive technique, what should be our strategy? So this is a lot of data coming in that what should be the strategy if we have the cardiac output? What should be reactive or should be proactive? So basically, what they have seen, that what they have shown, that there is improvement in the outcome if we are more proactive. Rather than waiting hypotension ho aur uske बाद हम treat करें, you should be proactive, and for that we need to have some kind of invasive monitoring where we can actually predict that patient may become hypotensive for a period of time. So as I said, there is a lot of literature coming in, and which is supporting to be proactive in managing the hemodynamics. So in conclusion, having invasive, minimally invasive, or non-invasive technique will not give the answer. It is basically the intervention that is required from the physician. The physician, if he is not in the OR, then these devices are useless. So cardiovascular monitoring system plays an important role in providing the perioperative hemodynamic management. The use of hemodynamic monitoring device per se in the perioperative setting has not been linked to improve outcome. It is basically the measurement, interpretation, and the intervention that has improved the outcome. So the most appropriate system must be selected for individual patient prior to surgery, taking into consideration the individual risk of patient and the procedure. And to improve the patient management outcome, the clinician must understand the advantages and the limitation of the various tools and parameters used during the perioperative care. Thank you very much.
Thank you, Dr. Khalid, for this useful and comprehensive talk. I have actually a question. As you mentioned that all these monitoring systems, they have unique characteristics in terms of their reliability and validity. So and it's kind of trade-off between invasiveness and accuracy.
Exactly.
So I want to learn about your experience at your institute, that what kind of measuring devices you are using and what is your selection criteria in terms of patient-to-patient variability.
Okay. So basically, we have mainly we are using 3 devices for measuring the cardiac output: transthoracic and transesophageal cardiography, and then we are using pulmonary catheter, and we have esophageal Doppler technique available in the OR. So again, it depends which scenario we are talking about. For example, in cardiac surgery, we are more inclined toward using pulmonary catheter, but in some case we use TE as well. But again, when we are talking about comparison with TE with the pulmonary catheter, pulmonary catheter is much more, we are more comfortable with it because it is in the patient all time. So we can have the parameters whenever we want. But with TE, you cannot keep it for a long time. Or so either we can do a single study over a period of 24, 48 hours, but with PA, we get continuous information, and based on that, we can do our intervention. Either we are giving fluid or we are using inotropes or vasopressors. But the key here again is how invasive we want to be. So for example, if a patient is coming with a EF like 30-40%, so if I'm comfortable doing this patient without pulmonary catheter, but I may think that this patient may require pulmonary catheter in the post-operative period, so I just put in the sheath intraoperatively and see how patient behaves. So it's basically your with over a period of time, your expertise defines actually what monitor you want for monitoring the cardiac output.
Are there any other questions? So we are going to move to our next talk, and that is the recent advances in perioperative fluid therapy by Dr. Sami Askar Dogar. He is serving as a consultant anesthetist in Aga Khan University Hospital, Karachi, with interest in pediatric anesthesia, sustainability in anesthesia, global health, and critical care. Additionally, he holds the position of director of anesthesia in Aga Khan Hospital, and he is also mentor at WHO Virtual Secretariat for Global Surgery.
Thank you very much. So in my medical school, I was very clear about fluids. I was taught that always start with crystalloids. When you have given too much of them, switch to colloids. No one actually told me what is too much, but I assumed somewhere between 3 to 6 liters. And if the patient is still hypotensive, give blood. Thankfully, now there has been an explosion of scientific papers on fluid management. Ironically, even after delving deep into the sea of knowledge, we are now swimming in a pool of confusion, desperately searching for clarity. So my aim today is to find that clarity. So outline of my presentation would be crystalloid versus colloids. I will talk about HETA starches and gelatins. I will talk about role of albumin. And then within balanced crystalloids, I will talk about normal saline versus ringer lactate and some literature regarding administration. So the debate of crystalloid versus colloid will probably continue, but it's dying down a bit. And in practice, crystalloids are generally preferable because they are cheaper and more readily available. We will talk about albumin, and we will talk that there is less favorable evidence about starches and gelatins. So 2013 was not a good year for starches. There were 2 systematic reviews. One involved 69 studies, 65 randomized controlled trials and 4 quasi-randomized controlled trials and 30,000 participants. And it showed that starches were related with increased risk of blood transfusion and increased risk of renal replacement therapy. So this was another review article in which starches were compared with saline, and they found that although there is no difference of mortality, but patients who were treated with starches required renal replacement therapy in a greater number compared to the crystalloids. This was the famous chest trial. So this was another trial comparing starches, and it also concluded that there is increased risk specifically in the subgroup of septic patients compared to non-septic patients. But after a few years, there was re-emergence of evidence in favor of starches. So in 2016, European Journal of Anesthesia, this article, it found that there is no statistically significant difference between starches and crystalloid in terms of mortality and renal replacement. But the authors also noted that the eligible trials were too small to draw any firm conclusions on this issue. So then this trial came, the FLASH trial. It also showed that there is no evidence of harm comparing crystalloids with colloids. And this 2022 meta-analysis compared starches for fluid management in patients with major abdominal surgery. And it also noted that they are not associated with increased risk of ATI after 30 days post-op. However, it's important to note that these newer studies, which have demonstrated no evidence of harm, they are using third-generation starches, which have low molecular weight. And most of these studies have compared starches with normal saline. And later in our presentation, we will talk that there are also some problems with normal saline. And it's also important to note that although these meta-analyses say that there is no increased risk of renal injury, but the results were consistent with previous ones, suggesting that use of starch was associated with a higher transfusion rate. What about gelatins? So since gelatins were banned in US several decades ago, so we don't have the same bulk of evidence for gelatins as we have for starches. It's important to note that gelatins have a molecular weight which is much smaller than starches, and the volume effect of gelatin is 70 to 80%, and the duration is 2 to 3 hours, which is also less as compared to starches. All the available literature, although it's quite old, but it suggests that they have shorter duration of action, they are less nephrotoxic, they affect coagulation, and there are increased risk of bleeding, and they have a relatively high incidence of anaphylaxis. So this was also a meta-analysis comparing gelatins with crystalloids, and it showed that there was low certainty evidence for increased risk of transfusion. Data for RRT was not reported in this review. And this was one big study which saw that there was a massive bleeding was much more common in the group who received gelatins compared to normal saline. So still, there are some diehard fans of these synthetic gelatins, and the arguments that they give are that maybe the impaired renal function is an outcome of impaired hemodynamics, and they think probably people who have impaired hemodynamics, they tend to get more colloids. So they think that probably hypovolemia or inadherent fluid overload with colloid was associated with organ failures. They also say that the dose of intravenous fluids can have important impact on the outcome, and a certain volume may be safely used without increasing renal related outcomes. And in several these studies, the initiation of renal replacement therapy was considered as an outcome parameter, but the initiation of the therapy in a lot of these trials were not standardized, making this a weak endpoint. However, my closing remarks regarding colloids are that bulk of evidence says that they are more harmful, and some evidence say that they are equally harmful. No evidence seems to support synthetic colloids superiority over crystalloids regarding patient safety. So there may be confusion that they are more harmful or they are equally harmful, but the trials do not show its superiority over crystalloids in terms of patient safety. So important to note, as I said, the gelatin was withdrawn from US market in 1978. FDA and European medical agencies have issued multiple warnings against HETA starches. In 2021, the FDA required additional warning about risk of bleeding and death and acute kidney injury for HETA starches. So until these warnings are withdrawn, there is very weak medical legal justification for using synthetic colloids. So now let's discuss albumin. Human albumin is pasteurized and does not transmit any known infections. It's available in 5 and 25%, also available in 4 and 20%. In my center, we have 20% albumin available. It is very expensive. It has proven role in certain conditions like spontaneous bacterial peritonitis and hepatorenal syndrome. So the real excitement about albumin began with the Albios trial. It was a multi-center trial, 1,808 patients, and albumin was supplemented for 28 days to maintain an albumin concentration of 30 grams per liter, and no difference was observed either in mortality, but the patients with septic shock showed a low risk of death. Relative risk was 0.87 with a confidence interval of 0.77 to 0.99. But it is important to note that this was a post-hoc analysis. This was not intended at the time of making the study design. It was a post-hoc analysis. But then there was lack of evidence in favor of albumin. Little or no difference between using albumin or FFP for using crystalloids, and little or no difference in terms of the need for renal replacement therapy. And then there was also evidence of harm for albumin, in which 5% albumin increased the risk of acute renal failure for both synthetic colloids as well as for albumin. So albumin 20%, 50 mils bottle in my center cost 14,500 rupees. The significant cost and lack of concrete evidence do not play in favor of albumin as a peri-op fluid, especially for low middle income countries. So overall literature favors crystalloid over colloids because of their increased safety profile and being cheap and easily available. But next big question is which crystalloid? Balanced crystalloid like ringer lactate or normal saline? So the volume expansion effects of saline versus ringer lactate, conflicting evidence. There were few experimental models which show that normal saline had a better volume expansion, 10% better volume expansion result. But there were other experimental models which showed that ringer lactate was better because in normal saline groups, they required more inotropes to maintain blood pressures. So what are the problems in normal saline? There are two problems. It causes acidosis and it causes hyperkalemia. So this was a study in which they saw that the saline group required administration of catecholamines for circulatory support more than the ringer lactate group. This was another study which showed that in the patients who had normal saline, there was increased need for vasopressor support. Several studies report that normal saline as much as 2 liter decreases renal artery blood velocity, decrease renal cortical tissue perfusion, decrease urine output, and decrease renal cortical perfusion. So this was a famous split trial which compared balanced crystalloid with saline, and it noted that there was no it did not reduce the risk of AKI. Balanced crystalloid did not reduce the risk of AKI. But the criticism on the split trial was that small volumes were used. The medium volume of study fluid was only 2 liter over a period of 90 days, and both study group received some amount of plasma light, which was a balanced crystalloid. Therefore, it is plausible that the prior administration of plasma light counterbalanced the effect of normal saline. So then there was the SMART trial. It showed a small difference in favor of balanced solutions, and the same authors then replicated their study and they did the SALTED trial, in which they showed that balanced crystalloid resulted in lower incidence of major adverse kidney events. So arguments for using saline. First is in the literature, you would see that normal saline is cheaper. Ringer lactate is 25% more expensive per liter, and the cost difference of plasma light and normal sol isn't much greater in the USA. But this argument is not relevant to our settings because when I have searched, ringer lactate is actually cheaper than normal saline. So while searching that, I also found this interesting thing that 500 mils bottle of saline is more expensive than 1 liter bottle of saline. I don't know why, not related to our discussion, but anyways. So next, when we are discussing balanced crystalloid versus normal saline, the argument against ringer lactate is that isn't safe in hyperkalemia because it has a potassium concentration of 4 MEQ per liter. In fact, ringer lactate is fine in hyperkalemia. Normal saline should be avoided in hyperkalemia, and fear of ringer lactate in hyperkalemia appears to be entirely theoretical. There are 3 reasons. One is that administration of ringer lactate to a patient with hyperkalemia will pull the patient's potassium towards 4 MEQ. The volume of distribution of potassium is very large, and 98% of potassium is inside the cells. Intracellular concentration is 140 MEQs per liter. So potassium shifts predominantly determine the serum potassium levels and not the administration of exogenous potassium in ringer lactate. And in fact, normal saline results in acidosis, and acidosis is known to cause hyperkalemia. So where is the evidence? So they did these studies in which they compared potassium levels in patients who were administered ringer lactate and normal saline, and they found that the patients who received normal saline had a higher potassium level. This was another study in which they compared ringer lactate and normal saline in terms of the serum potassium levels, and they noted that in the normal saline of the group, the potassium levels were higher, which was significant at 3rd and 4th sample. So the other myth is that ringer lactate will elevate the lactate levels. So in this study, they gave a 30 ml per kg bolus of ringer lactate versus normal saline, and they found that there was no significant difference in lactate levels in both the groups. Then there is a concern that ringer lactate isn't compatible with some drugs because it contains calcium. This is a legitimate concern, but it shouldn't be a problem if you have more than 1 IVs, which we usually have. So there is also another myth that ringer lactate is not safe with blood because it contains calcium and it can cause clotting. So there are also several studies which have addressed this. Can ringer lactate be used safely with blood transfusion? They found no significant difference. This was another study in which they found that ringer lactate can be used with blood, and there was no evidence of activation of clotting cascade. And another study which found that it's safe to be used even as a diluent for packed RBCs. This was one study in Canadian Journal of Anaesthesia, which noted that after 60 minutes, if you use it as a diluent, after 60 minutes, there may be some evidence of clotting, but if you are administering it within 60 minutes, there is no evidence of any clotting. So what about the use of ringer lactate in diabetes? We also have this that we use normal saline in diabetes. So there is a fear that lactate will convert into pyruvate, which would result in increased glucose levels. So historically, lactate-containing solutions were not recommended in diabetes because they were thought to exacerbate hyperglycemia. So this was a study by Association of Anesthetists in the journal Anaesthesia, Perioperative IV Fluid in Diabetics. Don't forget the salt. And what they noted was that lactate is a 3-carbon compound and glucose is a 6-carbon compound. If 1 liter ringer lactate, the 29 millimoles of lactate would yield 14.5 millimole of glucose. This is assuming that the biosynthetic pathway of gluconeogenesis are 100% efficient. There is no lactate is oxidized, and all lactate is administered instantaneously. So if all these assumptions are met, 1 liter would increase glucose levels by 1 millimole per liter. However, regarding diabetic ketoacidosis, now the evidence favors balanced crystalloid. They have shown that ringer lactate is superior to normal saline. So this is a study in which they evaluated the use of normal saline versus balanced crystalloid in diabetic ketoacidosis, and they found that treatment with balanced crystalloid resulted in more rapid resolution of diabetic ketoacidosis. So this was another review article in Heart and Lung, and it also noted that balanced crystalloid solution in diabetic ketoacidosis was associated with faster rate of ketoacidosis resolution compared with normal saline. And this was also a systematic review in which, RCT, in which ringer lactate was shown to be superior to normal saline in terms of elevating DKA quicker in their study. So what about anions in balanced crystalloid? So for ringer lactate, liver accounts for disposal of 60% of the circulating lactate and the kidneys for the disposal of 25 to 30%. The body has immense capacity for lactate disposal if necessary. It's like, for example, in exercise, the rate can rise as much as 500 millimoles per hour. And sodium lactate infusion has been shown to improve cardiac function. There are some studies which say that it improves cardiac function. So what about sodium acetate? It is also rapidly metabolized into bicarbonate, lactates beneficial cardiac effect. Excessive acetate level may cause, however, vasodilation and hypotension, but this does not seem to be clinically relevant as it will be rapidly metabolized and only transiently present. What about gluconate? Although often believed to be metabolized into bicarbonate, this doesn't seem to be the case. So sodium gluconate does not function as an alkali, unlike sodium acetate and sodium lactate. Sodium gluconate appears to be cleared unchanged from the kidneys, and it could even function as an osmotic diuretic. So some other concerns with ringer lactate are the elevated intracranial pressures. It is slightly hypotonic, so it would raise ICP, but in practice, the raise in ICP would be as much as it would be from 1 liter of normal saline plus 150 ml of any drug, which is made in 5% dextrose. And then it's also contraindicated in metformin-associated lactic acidosis because the body doesn't have capacity to metabolize lactate in that condition. So, and the other contraindication for ringer lactate is hypercalcemia. There is also a theoretical risk of worsening hypercalcemia because it contains 1.5 millimoles of calcium. So concluding remarks about crystalloids is that overall the contraindications to balanced crystalloid are uncommon and fairly mild. Outside the neurological ICU, ringer lactate would be an excellent safe choice for patients. So now 4 Ds of administration by the International Fluid Academy. So the 4 Ds of administration are drug, dosing, duration, and de-escalation. So fluids are drugs with indication, contraindication, and side effects. The dose makes the poisons. So timing and the administration rate are equally important. In contrast to most drugs, there is no standard therapeutic dose for fluids. Duration, while the clinicians are usually very clear about the starting triggers for fluid administration, there is quite a lot of debate and confusion about the stopping triggers for fluid resuscitation. And then there is the concept of de-escalation, the final step in fluid therapy where you would want to withhold or withdraw fluids when they are no longer required, reducing the risk of fluid overload and related harmful effects. So talking about fluid management before surgery, ideally we should replace pre-op deficits. However, they are very difficult to detect and trial regarding preloads are discouraging. Fluid management during surgery, historically, we had the wet approach in which we would use large amount of crystalloids in major surgery. Recent evidence favors restrictive fluid strategies, but the definition of restrictive and excessive are arbitrary. And there is a question that the benefit of restrictive, is it the benefit of restrictive or is it the benefit of avoiding excessive fluid? Then fluid management after surgery should not compromise healing process. It should avoid fluid balance, and it should, and which fluid we should use, isotonic or hypotonic for maintenance fluid post surgery, and the role of de-escalation. So regarding isotonic fluid versus hypotonic fluid, the pediatric literature favors hypotonic fluid. But in adults, there are concerns of hyponatremia with the use of hypotonic fluid. But there was this trial, Tomset trial, which noted that the hyponatremia by hypotonic dextrose-containing fluids was only mild, and using isotonic fluid administration in post-op phase resulted in a more positive balance compared to the groups which received hypotonic fluids. So de-escalation. A traditional approach to give fluids to overcome anesthesia-induced vasodilation, which I said was wet approach. Fluid overload results in edema, SIRS, and organ dysfunction. De-escalation was first suggested in 2012 and later coined in 2014. It refers to the late goal-directed fluid removal. However, how to de-escalate it is still a lot of confusion about it. One approach is to use albumin with furosemide, and the other approach is renal replacement therapy. So there's a lot of debate how to de-escalate. So 5 steps of de-escalation are: define a clinical endpoint, set a fluid balance goal, set perfusion and renal safety precautions, like if there is need for vasopressor or if the creatinine clearance decreases, you have to stop de-escalation, re-evaluate after 24 hours unless safety limits are reached, and adjust the plan accordingly. So my closing remarks are: fluids should be prescribed with the same care as any other drug, and every effort should be made to avoid their unnecessary administration. And it is important to acknowledge the inherent challenges in conducting standardized trial in critical care settings. So we should seek guidance from whatever available literature or evidence is, not merely dismissing them based on their limitations. So this is the professor at London School, and he quoted Bradford Hill that too often I suspect we waste a deal of time. We grasp the shadow and lose the substance. We weaken our capacity to interpret the data and to take the reasonable decisions, whatever the value of P. Thank you very much.
Thank you, Dr. Sami, for that wonderful talk. So we've already got an online question regarding this. So in a patient with chronic kidney disease, what would be your choice of fluid management and why?
So we have seen that in patients who have chronic kidney disease, these normal saline and colloids, they are already causing renal injury. So the best approach would be to use balanced crystalloid. And also, I think I didn't have time, so I included this specifically in my talk about use of fluid in renal patients. So in patients with severe metabolic acidosis, especially I'm talking about the uremic acidosis, they recommend that we use a bicarbonate containing apna fluid. So bicarbonating containing fluids are much superior compared to balanced crystalloid and normal saline in renal injury. Yes.
Dr. Sami, you have a question, please. Yeah.
Hello, so Irfan here, hepatobiliary surgeon. So just a quick question. We talked about patients in fluid balance in acidosis. What if the patient is going the other way and is alkalotic? What do we do in that situation?
Yes. So as I told you that I had too much slides and my boss asked me to remove some of them. So there's also this concept of, can you please turn on that presentation for a minute? So there is this concept of pH guided resuscitation, in which what they say is that you see if the patient, you're starting with the patient, if the patient is alkalotic or the patient is acidotic. So if the patient is alkalotic, then they recommend using normal saline because it would balance the pH. And if the patient is already in metabolic acidosis, then they recommend using isotonic bicarbonate. So what they say is that fluid resuscitation is also a chance to optimize pH. So with this concept, you can decide choosing between normal saline and lactate.
So Dr. Sami, I have a question. So my question is that today there is a lot of talk about the enhanced recovery program.
Yes.
And which actually empowers the patient in the preoperative period to take the control of their own hydration status. So don't you think that we as perioperative physician should take the charge to improve the patient's metabolic status, and that can make our task of intraoperative fluid management much more easier? Because our patients are mostly in a catabolic state with 8 hours of fasting, with not only for solids, but also for liquids, because most of the time they are not educated about the 2 hours fasting for clear liquids.
Yes, so I totally agree with this. And I think all these recommendations by the enhanced recovery, they are in line with moving away from the wet approach, in we would give them a lot of fluids. So probably they are more in line with the restrictive fluid strategies. And they have also seen that algorithm-based fluid administration is always superior to non-algorithm-based fluid administration, because they think that with non-algorithm-based fluid administration, there are more chances that you would result in fluid overload, or you would probably give underacetate. So I think we should definitely take that in consideration.
Thank you so
Thank you.
So basically, the fluid is a very complex topic. And for those who have been practicing for the last 25, 30 years, they still are struggling on which type of fluid. But I believe that it's more beyond the type of fluid. It's whether the patient needed it or not. This is, I believe, the most important question. Because if you wanted to learn about the hemodynamic coherence, so we talk about that it's a clinical target or the physiological target. So you might have a patient who has a very nice macro circulation. His BP is good, his heart rate is good, but he has a high lactate, and he has a poor base deficit. So it means that you need a very good amount of fluid if you are considering that this would be the reason behind it. But if the patient is tachycardic, but he has a very normal clinical targets, all things are normal in terms of acidosis and lactate is pretty fine. So do we need to follow the same algorithm on the basis of that he needs a fluid because this is my training that I have to give the fluid to him. So that's why the concept of the fluid stewardship, that whether it is needed, whether it is not needed. So I believe that not every patient requires going with the high amount of fluid or the fluid boluses, rather than you only keep with the maintenance fluid, whatever the formula we usually use to go with it. That would be the best choice, I believe, rather than we always think about what type of fluid we need to give, because everything, the body is not habitual to the saline, body is not habitual to the lactate, body is not habitual with any bicarb solutions or that. Whether it is needed, you may need to give, but the sort of thing you have available. If it is not needed, better avoid it.
rightly said, Dr. Faisal. Thank you, Dr. Sami. All right.
डॉक्टर फरहान मैं ये सिर्फ आई वांटेड टू आस्क के आप लोग कभी भी हिमोसिल यूज करते हैं या नहीं यू स्टिल यूज हिमोसिल लाइक इट्स बीन इन अमेरिका okay
Yes, so we still use Hemisil, and it is a lot on personal preferences. We have that available in our formulary. Some people don't use it, but some people still use it. Yes. Gelatin. So usually I also personally think that although there are concerns about anaphylaxis and increased risk of bleeding, but in a lot of situations when we have to use these gelatins, it is already it's already a disaster. It's a massive hemorrhage. Patients would mostly end up in ICU. So it becomes really difficult to identify if you have caused any further damage, because if someone had a hypovolemic shock, someone lost a lot of blood, then you are already expecting that maybe the kidney function would go down. There would be dilutional coagulopathy. So probably I think this is one reason why still some people use gelatin, and we don't really see these kind of problems which the literature says, because the patient end up in ICU anyways.
I just feel, thank you, Dr. Sami, great talk. I feel obliged to just point out one thing. Many of these studies, these larger trials have fancy and comprehensive statistical analysis. So we talk about stuff like, and I hear this all the time about how, oh, this patient was already very sick. Kafi bimar tha, isliye they were already in shock. That's why you use gelofuscin. So that was a confounding factor. But a properly designed trial is designed to control for these things. They do control for things like age, the severity of diseases, the amount of blood loss they've had, the type matching for the types of surgeries. So it's easy. And this is for the trainees here. Don't dismiss this, okay, oh, our patients are sicker. I'm sorry, but that is just not true. Everybody has sick patients. They do design these trials to account for these things. So this adage, in my experience, or my patient was sicker, therefore it's not an issue. Do look at the study, do look at whether it's designed or not. So that's why this, what you presented about how in these controlled trials, as well as well-matched patients, well-analyzed groups, they were able to find differences.
Great, sir.
Thank you.
Thank you very much.
So I would like to invite our next speaker, Dr. Mansoor Nawaz Bangish. He's consultant anesthetist and intensivist in University Hospital, Birmingham. He's also a PhD and honorary senior lecturer. He has over 40 publications on liver failure, sepsis, acute kidney injury, ARDS, and COVID-19. And his top talk is about the post-operative complications across the spectrum of liver diseases.
Okay, thank you very much for that kind introduction, and thank you for inviting me here. Again, this is my second year of speaking at this great conference. I'm very pleased to be here. So just in terms of declarations, none of these companies have got anything to do with the talk here, not even the one with the liver insignia, so don't worry, there's no conflicts of interests. So I want to start off by considering a scenario which you may come across frequently. So, imagine a relatively sort of young, middle-aged male, not particularly very much medical history, but he is known to have cirrhosis. Maybe that's due to a fatty liver disease. When you look at the patient's blood results, when you look at the patient's preoperative imaging, and when you look at the patient clinically, there's no evidence of severe cirrhosis. And in fact, you can label the patient as Child-Pugh A, which is really the mildest form of cirrhosis, according to one of the classification systems. And the patient needs to have the tumor excised. There's no metastases. And between the surgeons and the anesthetist, they decide that they should go ahead with the surgery. But because of the slightly higher risk, they're going to put the patient into an enhanced recovery post-operative position, but not necessarily send the patient to HDU. So, of course, the patient is brought to the anesthetic room. The induction is completely fine. An arterial line is cited for some perioperative monitoring. Nobody puts the central line in because they think that this is a relatively straightforward operation. But if there's some requirement to support the blood pressure, they're going to support this peripherally with intravenous metaraminol. And everything is going fine. The patient is being prepped and draped. But unfortunately, once knife is put to skin, they open the abdomen, and to everybody's great surprise, they find that there's large volume ascites, which wasn't there on preoperative imaging. So I'm going to give you three choices, and I'm not trying to catch anybody out here because this is a real scenario. It happened in my hospital, and the decision of the surgeons and the anesthetist was to proceed. But out of you, just show of hands, who would proceed under these circumstances? Okay, so that's a reasonable number of, I think, the few senior members here that I've seen that would proceed. And who would abandon? So that is to close the patient and return them. So I think that's the hepatobiliary surgeon, if I'm right, he would abandon. And who's a bit unsure, maybe would ask Ehsan Khan and say, what should I do, boss? Okay, so a couple of people unsure. So I'm going to come back to that scenario in a moment, but, why do we worry about liver diseases? This isn't really a big feature of something that's taught on anesthesia and intensive care curriculum. And if it is, it's more about pharmacology. Nobody really bothers too much about it. But this slide shows data from the United Kingdom over the last 40 or 50 years. And essentially, it shows that almost every major medical cause of death is on the decline. But it's quite the opposite trend for liver diseases. The mortality for this is not just increasing, but it's massively increasing. And in fact, there's the same problem in Pakistan. We know that there's a massive problem with viral hepatitis there. Probably there's about 10, at a conservative estimate, 10% prevalence of the disease here. And there's also a growing problem with fatty liver disease. So even if you go to rural areas where food intake is poor, we think that there's probably a 10% prevalence of fatty liver disease there. When you become to more affluent areas in the cities where food scarcity isn't as much of a problem for these communities, we're talking about an almost 40 or 50% prevalence of fatty liver disease. And in a very high-risk group with type 2 diabetes and metabolic syndrome, you could see 3/4 of your patients with fatty liver disease. And this is going to become a bigger problem for Pakistan, because if you look at the obesity data in Pakistan, it's on the increase. There's another problem with fatty liver disease, though, and that's that there's a lean phenotype. So there are patients out there who don't have diabetes, who look like they're slim, and yet they have fatty liver disease. And so these patients aren't always obvious either. So going back to the scenario, really what you need to know to be able to make the decision is what are the risks of surgery in a patient with cirrhosis, and how does it compare if the patient is compensated versus decompensated? You also need to know what you are likely to encounter if you do proceed. And you also want to know what can you do to mitigate the risk of it. And once it's happened, of course, you need to know how to manage it. So just looking at the data, so this comes from a paper looking at roughly 8,500 cirrhotic patients from the United States. And if you compare the group with no cirrhosis to the group with cirrhosis, the odds of death are increased by roughly 4 to 5 times, depending on whether you look at post-op mortality at 30 days or 90 days. So that's shown here on this graph. And, you know, the difference is clear, but it doesn't look that impressive. But this is for elective surgery. When you go to emergency surgery, the 3 groups, so that's cirrhosis in the blue line, and no cirrhosis in the red line, and then no cirrhosis but chronic liver disease. So here, this is chronic hepatitis B infection, but no cirrhosis. First of all, the mortality for all of these groups is much worse. We expect that, it's emergency surgery. But what's really interesting here is that even without cirrhosis, but just the presence of chronic liver disease, there's a massive fall off in mortality. So other studies have looked at what influences outcome in surgery on cirrhotic patients. And the take-home message of this is that the severity of the surgery is very important. So this is again in the elective setting. And the dark blue line at the top is basically for laparoscopic abdominal surgery. So that has the best outcomes in these patients. But the dashed green line at the bottom with a very high mortality is unfortunately for open abdominal surgery. And there's a comparator for major orthopedic and vascular somewhere in between. In specific instances where you not only do abdominal surgery, but you do abdominal surgery on the liver, and one of the biggest risk factors for death and post-hepatectomy liver failure is liver cirrhosis. And the odds of death go up by 55 times compared to baseline. So it's a really important factor for mortality and for liver failure post-operatively in that specific group. But our patient, of course, we knew he had cirrhosis, we knew he was having abdominal surgery. The question is, what difference does acute decompensation make? Well, if your patient has had previous bouts of acute decompensation, but presents to you in a compensated state, it doesn't matter about their history. But it turns out that if they present to you with an acute decompensation, their risk of a poor outcome goes up by 3.5-fold. So what about assessment? Because when the patient's on the table and you come across with this problem, that's a slightly different issue. How can you prevent this happening? And that's all about assessing your patient. And in order to adequately identify which patients are at risk, what we really need to understand is who has clinically significant portal hypertension. And the problem there isn't so much identifying who has very bad hypertension, but it's about who has moderately severe portal hypertension. And the reason for that is because it's latent and it's difficult to see. So this is a bit of a busy slide, but essentially it shows the morphological changes that you expect with liver as liver disease progresses. So in this case, we show fatty infiltration, steatohepatitis, which is an inflamed fatty liver, progressing to fibrosis. And these F marks come from hepatology. These are histological grades of fibrosis. And true fibrosis only really begins at F4, but you can see that it can progress to very severe at F4C as compared to F4A. Now, along the bottom, what you see is the symptoms and the states that you expect for the patient. And the important thing is that in compensated cirrhosis, many patients have varices. But the problem is that despite the fact that many of these patients will have cirrhosis and varices, they are completely asymptomatic. They're walking around and you can't tell who they are. One other important thing to point out here is that there's this parameter called HVPG. Doesn't really matter what its name is, but essentially it's a surrogate marker for portal pressure. And the portal pressures that distinguish between these different states are quite well marked, up to about 10 millimeters of mercury. Between 10 and 16, there's a gray area, but pretty much beyond 16, you know that the patient has very severe portal hypertension. So there's a gray area between 10 and 16 when you actually measure the pressures as well. And we'll come on to talk about why that's important. So is this portal pressure really important? So what this graph shows here is the outcome over 12 months for patients with cirrhosis who present for major surgery. This was a prospective study. It was done in Europe. They measured the portal pressures in these patients a couple of weeks before they went for surgery. They had their surgery, and then they had a look at what happened to them. So the black line close to the middle shows the outcome for the whole group. But what the other lines do is they show what happens for outcomes when you list patients according to their portal pressures. And the lower portal pressures are at the top, and you can see that their survival is much better over a year. And the worst portal pressures are at the bottom. And essentially the group level outcome, which is the black line, the worst outcomes are experienced at roughly portal pressures of 20. But portal pressure of 16 or 14 is pretty close to observed as well. So there seems to be an inflection point around 16 to 20 for portal pressure, but that's that gray area, which is very difficult to identify clinically. And it's in that gray area, which is also a little bit unclear in terms of portal pressure cutoffs from hepatology data. Now that is over a year, but if you actually shrink down the curve and you look at 30-day outcomes, which are much more sort of in line with what we look at as intensivists, even the difference between these different portal pressures are visible here. So this idea of portal pressure at baseline determining outcome is really important. So how do you know there's significant disease? Well, luckily, there's a test called elastography, or you may know it better as FibroScan. It's non-invasive. It basically uses an ultrasound pulse and detects the reflected wave, and it comes up with a pressure. And the pressures that this device gives correlate really well with portal pressure, up to about 11 millimeters of mercury. Now, 11 millimeters of mercury is roughly where patients are asymptomatic. So this is really useful for telling you who you don't need to worry about. If you get a reading which correlates with 11 millimeters of mercury or less, you can be satisfied that your patient is low risk. One of the problems with portal hypertension, though, is that elastography measures what the texture of the liver is doing. And as your portal hypertension gets worse, it tends to rely less on changes in parenchymal texture and much more on flow-related phenomenon. And so elastography starts to give you numbers which are basically misleading. So when you start to get to higher levels of portal hypertension, the number on elastography is not going to be useful for you. And that means that it's a great test to say that your patient is low risk, but it's not such a great test to tell you, is your patient in that borderline area? And the gold standard really for finding out whether your patient is in that borderline area is essentially invasive measurement, or to do an endoscopy and actually look for gastric portal hypertensive gastropathy, or to look for small or large varices. Luckily, these are surgical patients, and usually they're coming for abdominal imaging, and so the surgical workup is often helpful as well. So you can look at things like spleen size, you can look for the presence of varices there as well, and these things often give you a clue as well. The good thing is that apart from traditional measures of liver disease, such as Child-Pugh score and MELD, there are actually some specific calculators designed for anesthetists. So this is where the anesthetist can become a hepatologist. And they use different parameters which are available from laboratory testing, but essentially they also take into account comorbidity and age. There's also worth mentioning that from the medical hepatology side of things, there's a CLIF, which is the European Consortium for the Study of Liver, acute decompensation score. And the important thing about this is that it uses a slightly different set of parameters, but very importantly, they can identify two groups of patients, one that is extremely stable and very unlikely to have mortality over the following 3 months, and another group which is extremely high risk and very likely to have mortality over the coming 3 months. But again, there's a gray area here, and we'll come to that gray area in a moment. So coming back to the Mayo score, the problem with the Mayo score is it's very well established, but it's old. Now that dashed line is the perfect score. And essentially what this shows is that from 2008 to 2010, when the score was first developed, the line was pretty close to the dashed line and it performed reasonably well, except when you went out towards extremes of patients. But as the years have gone by, this score performs less and less well. And the reason for that is because surgical techniques have got better and anesthesia and intensive care has got better. The vocal pen score, however, when you compare it to the recent data from Mayo scores, seems to behave really well. And so the key message here is that if you want to pre-assess your patient, you should use the vocal pen score. So the suggested pathway for these patients so far is when they present to you, you need to look at a variety of these factors. And essentially, if they're Child-Pugh A patients and if they're having low risk surgery, you should probably just proceed as long as you've consented the patient and informed them of the risks. And similarly, if it's totally obvious that the patient has end-stage liver disease, then really you either need to abandon, consider palliating the patient, or potentially look at non-surgical alternatives. So that doesn't touch on the gray area in between. We'll come on to that, but it's worth understanding what happens to the patient intraoperatively to understand why we need to think differently about that group in the gray area. So the first thing is that systemic hemodynamics change. Now, this is estimated hepatic blood flow, pre-induction, and essentially post-induction. And you can see it drops off massively. That's just from open abdominal surgery, but even with laparoscopic surgery, which we know is safer, the difference between using a high-pressure pneumoperitoneum and a low-pressure pneumoperitoneum clearly has an influence on liver function tests at day one. And thankfully, they're only very mildly raised here because these patients are normal. But the point is that what you do to your patient intraoperatively will definitely affect the liver. Now, that's sort of surgery which has gone well as expected. But what happens when your patient bleeds? What happens if you have to turn them prone because they're having an AP resection? What happens if they need high PEEP? What happens if you need to control blood flow into the liver? You need to do a Pringle maneuver. Well, then you get cycles of hepatic ischemia reperfusion. And what you see here is basically, you can't do these things in human beings. So this is from rats, but this is essentially a liver lobule on the left under a microscope, and it's fluorescing and it's nice and healthy. And after a period of hemorrhagic shock, what happens is that it suddenly lights up. Now, what's lit up here are cell death proteins. So these are activated after hemorrhagic shock. And what that means is that your patient is going to start to lose hepatocytes every time they lose hepatic perfusion. Also, what happens with these patients is that as you manipulate the gut, and because their livers don't work very well, you get translocation of bacteria and you get translocation of endotoxin into the system. And that sets you up for infection, for sepsis, and it can cause remote organ injury as well. So what does all of that change within the operative period do to a patient post-operatively? So again, you can't really do these experiments in humans. So this comes from a rat study. And essentially it shows a normal group of rats which are labeled as sham. And then there's a group of rats which have cholestatic cirrhosis. And essentially you can see that the portal pressures are much higher in the cirrhotic rats 2 days and 7 days after their surgery. But the difference between the white bar and the gray bar is that one has a laparotomy and the other one has laparotomy with intestinal manipulation. So much more like what you really do to a patient with surgery. And what you can see is that the portal pressures are significantly higher at day 2 and at day 7 after that. So basically, you already have portal hypertension, but after intestinal surgery, it goes even higher. And that's also replicated in a second model of cirrhosis. Why is that important? Well, this demonstrates how much ascites is built. And what I've done is I've put a blue marker to sit at portal pressures within that gray group that are really difficult to identify. Now, you imagine you just put 4 millimeters of portal pressure additional to that, and your ascites volume dramatically increases. So this is why you get post-op ascites in these patients because of the changes in portal pressure. And in the specific surgery where you not only operate abdominally, but you operate and do a hepatic resection, what you find is that the portal blood flow to the liver stays the same, But because the amount of liver there is much smaller, the amount of blood going through each volume or each unit volume of liver is much more increased. And what that does is that it stretches the sinusoids, it damages them, and it causes further liver problems. So high portal blood flows, volumetrically speaking, are also damaging in the specific setting of hepatectomy. So putting all of that together, we know that during these operations and subsequent to them, the patients are going to have a variable loss of hepatocyte mass. We know that there's going to be an increase in portal pressure and potentially portal blood flow if the patient's had hepatic resection. And this leads to post-op ascites. It predisposes to infection and sepsis, and that can lead to post-op hepatic decompensation, which in a patient with cirrhosis may lead to this syndrome called acute on chronic liver failure, or in the setting of hepatectomy, lead to post-hepatectomy liver failure. And that's really what drives mortality. So how frequent is this? Well, this study looked at a group of cirrhotic patients undergoing elective surgery and found that 1/4 of all patients will develop acute on chronic liver failure just because they had elective surgery. And this was in comparison to TIPS in the gray bars, which you don't really need to worry about. But if you look at when ACLF happens in these patients, it basically happens within a week. Roughly 10% of these patients will be presenting within the first couple of days, but certainly within a week, these patients will decompensate and have acute on chronic liver failure. So I've already told you that surgery is bad for these patients with cirrhosis. That's shown here in the blue line. Again, you can ignore the red line, which is TIPS. But this is the patients with ACLF in the red line. If you develop ACLF, this is what's driving your mortality. And so really what you want to do with these patients is avoid acute on chronic liver failure and actually predict acute on chronic liver failure. So what is acute on chronic liver failure? I've been talking about it, but you may not know what it is. It's a relatively new syndrome. There's some slight differences in definition between the American setting, East Asia, and Europe. But nonetheless, it's basically a multi-organ failure syndrome. And it's after a defined hepatic insult within 4 weeks leads to hepatic dysfunction. And very simply, if you've got grade 1 ACLF, you've basically got 1 organ dysfunction. Grade 2 is 2 organ dysfunctions, and grade 3 is 3 or more organ dysfunctions. If you look at the pattern of ACLF that you can expect to see in your patients, the vast majority of them actually have ACLF1, which means ACLF is manageable. And you should be able to, as long as you're forewarned about it and you have the equipment and the setup for it, you should be able to treat these patients so that they can have a good outcome. But having said that, even though most of these patients have ACLF grade 1, remember, this is what's driving mortality in the long run. So there's a certain amount of things that we can do about it, and there's a certain amount of we're stuck with the patient. Can we do anything about it? Well, I've spoken to you about the importance of portal pressure. There are no randomized controlled trials in this area, but there's propensity match scored studies which look at patients that had elective surgery and had a TIPS put in before surgery versus no TIPS. Now, a TIPS is a shunt, which basically is put in, and it basically diverts the blood flow from the portal system into the venous return, and basically means that you mechanically lower the pressure in the portal system. And what you see is that the patients that had a TIP and a mechanical reduction in their portal pressure, they had a significantly better survival when they went for elective surgery as compared to patients that didn't have a TIPS. And you can see in that cliff acute decompensation score in the gray area, when it's above 45, the difference between these patients is even greater. So maybe we can use the acute decompensation score to risk stratify these patients and target them for TIPS. So coming back to that diagram for the group in the middle, when you've got child Pu B or a patient with any of these other factors that are listed there, including ascites, that's really when you need to start having multidisciplinary conversations with your hepatologists, with your intensivists, and with your surgical colleagues. And you need to think about whether or not you should put a TIPS in these patients. Again, there's no direct evidence for this, and so it's not a straightforward decision to make. And you also need to consider whether or not these patients actually need to be sent down a different pathway. Can their non-transplant surgery, can it wait? And should these patients be referred for transplantation and then have their non-transplant surgery after that? Obviously, it's very difficult with cancer surgery, but this is something to think about. And some of these patients may not be suitable, and you have to have the strength to be able to put your hand up and say, we're not doing this operation. And hopefully with some improvement, better nutrition, tips placement and so on, some of these patients can improve their state to Charles-Pugh A, and they can be more safely operated on. So coming back to the scenario, I'm not going to go through it again, but in terms of what we did for this patient, this is a score from the portal pressure gradient paper. Essentially, the portal pressures in this patient were likely to be maximum of 13, and so they score 40 points, which we add to the total down there. They then, because they're in a compensated state, that automatically puts them in class 3. They score another 40 points and they move to 80. And then they're having high risk surgery because it's abdominal. You add another 50 points and you come to 130. And when you compare that to the 30-day transplant-free survival, which is essentially a marker of mortality, it's really good. So we did the right thing for this patient in choosing to bring him to surgery. Even his 1-year survival was very good. In terms of what happened on table, though, we had a different scenario. Something unexpected happened. And over here, we know that it's high-risk surgery. That's not going to change. But now, because he decompensates, he moves to ASA class 4. And what that does is it pushes his score up to 140. But of course, his portal pressure gradient, at least, is going to add an extra 90 points. Because, an extra 60 points, because it's going to be roughly 16 or 17 at minimum. And that's going to push his total score to 200. And if his portal pressures are any higher than this, he will have a higher score. And then when you compare that to the mortality gradient below, he's got a 15% chance of death within the coming 30 days, at least. And so, unfortunately, we actually proceeded with this patient, and it didn't turn out well for this patient. And we had to look back into the literature and understand what was going wrong. And this is at a tertiary liver center. So, there's only 7 centers in the UK that do liver transplantation. And this is what our anesthetist did. This is what our intensivist did. And it didn't come out well. So these things can go wrong. And it's important to be really informed of just how badly these patients can go if they're acutely decompensated. So just last slide now. So liver disease is very common. Significantly affects outcomes. You need to actively look for it, even in people that you don't expect it in, especially in this country. You need to risk stratify, and you need to ask hepatology if you're unsure, just like we ask cardiology when we're unsure. You need to consider whether or not a TIPS can improve your patient's risk score. There may be an opportunity to introduce non-selective beta blockers, but because of the data around beta blockers and perioperative outcomes, that's a bit unclear as well. And really, you should not operate on patients with end-stage liver disease, especially if it's an emergency. And finally, always plan for the unexpected. So when you're making your surgical and anesthesia plans, you obviously have a pathway that you expect the patient to go on, but you need to ask yourself, what will I do if the patient is unexpectedly decompensated on table? And you also need to ask yourself what you're going to do if the patient develops acute on chronic liver failure 3 days post-operatively. Thank you.
Thank you so much, Dr. Bangash, for this thought-provoking talk. And are there any questions? Yeah. That's what we were expecting.
So thank you, Dr. Bangash, for that fascinating talk. It's interesting to see the understanding of the physiology behind it. I worked with you in Birmingham between 18 and 19 with Paulo and Pereira. One of the issues we face here is there's a lack of critical care, trained people, and hepatology trained anesthetist. We do face these situations at times where it's an unexpected finding. And portal vein modulation is an important armamentarium to reduce post-hepatic liver failure. Have you got any experience with tying off the splenic artery to try and modulate the portal pressure? And does it affect the anesthetic side of things? That's my one thing. And this other thing was in terms of the fluid management for these kind of patients. Because what we face here is they get overloaded quite a lot. And then we're kind of facing the problems afterwards. So just those two things.
Yeah, so basically the idea of tying off the splenic artery basically the liver receives two sets of blood flow. So one is arterial. You really can't do anything about that, and you wouldn't want to do anything about that, but it has a portal inflow. And the portal blood flow comes from obviously the gut. It receives some blood supply from the stomach and from the spleen as well. And so the idea is that if you tie off the blood supply to the spleen, because it's not an essential organ for your life, you can reduce the blood flow into the portal system and reduce the portal pressures. So that's often done. I've seen it done in the setting of transplant surgery in patients who've had very severe portal hypertension and very high portal flows. It's not something that we do very commonly in the elective setting. Would you have done it in this setting for this patient? I think probably not. And the reason I say that is not because it wouldn't reduce the portal flow. It's probably because with this patient, in retrospect, you want to get out and do as little as possible to the patient. So if you're going to start tying off the splenic artery, you're going to have to start moving around organs. As soon as you move around organs, the portal pressures are going to go up. So in this particular setting, I would say no. And because it's so invasive, to tie off the splenic artery, there's probably alternatives. So there is the tips, obviously. There's things like splenic artery embolization, which can be thought of as well. But all these different strategies that you have that can reduce portal flow are likely to help. But of course, in the absence of a randomized controlled trial, we don't really know that 100% for sure. In terms of fluid therapy, I think that's a really important point with these patients. So the first thing is that there's no evidence that albumin helps these patients. So there have been recent studies looking at the use of albumin in medically decompensated patients, and it doesn't really make any difference to these patients. It's really expensive here. I don't think your patients can afford it. And if it doesn't give them any benefit, then why use it? In terms of how much fluid these patients get, I'm not surprised they get overloaded. And the reason for that is because when you've got a patient who's Child-Pugh A, they basically behave like you and me, so long as I've got no liver disease. But as soon as you sort of get into Child-Pugh B and Child-Pugh C cirrhosis, the hemodynamics of these patients is totally different. You can give them fluid and they will just accept it. And if you put them on your cardiac output monitor, first of all, the cardiac output monitor is not calibrated in cirrhotic patients. And the second thing is it will definitely tell you that the cardiac output is high, but basically you won't increase their cardiac output. Okay, so you'll give the fluid and nothing will change. And one of the things is that if it doesn't change, there's two reasons why it doesn't change. It's either because your patient is full or it's because they're so empty that you need to give them more. And usually what happens is that you're in the perioperative setting, you think, I've given the 200 mils of fluid, nothing's changed, I'll give another 200 mils. And so that's what happens with these patients. They have an enormous venous capacitance and they just absorb the fluid and they don't change their cardiac output. And so that's why these patients end up getting fluid overload. So I'm not completely surprised by that. And I think, it's very difficult to know what to do with these patients intraoperatively because a lot of the perfusion monitors don't work. So what do we look at? We look at lactate, but the lactate goes up as soon as you touch a liver patient for hepatic reasons, not for perfusion reasons. So a lot of the things that we rely on, cardiac output monitoring, blood pressure, lactate, these things are unfortunately almost useless, really. And, it may just be something as simple as capillary perfusion that ends up being the best monitor in these patients. So I'm afraid I don't have any answers for you, but I'm not surprised that fluid overload happens here.
So building up on the preoperative assessment, do you think I think we deal with a lot of patients who come in, who are sort of borderline, who got Child-Pugh A or lower. So should we have fibroscans in our sort of preoperative assessment? Or involve hepatologists early in their assessments. So what's your take on that?
Yeah, I think my feeling is that basically, even if your patient looks like Child-Pugh A, just you want to reassure yourself that it's not a Child-Pugh A who's in fact going to be a Child-Pugh B tomorrow. Because you see, everybody looks like a Child-Pugh A until they have an acute decompensation. So if I've got cirrhosis, and you even measure my portal pressure today, and it's nice and low, and you classify me as Child-Pugh A, if you come and see me in a year's time, you'll say, he looks all right to me. I've measured his portal pressures. He's still, biochemically he's the same. But what you don't know is that the day after I'm going to have a variceal hemorrhage, As soon as I've had a variceal hemorrhage, actually, that tells you clinically that I'm a different patient. So patients change and patients don't behave. The correlation between classification systems and actually what's happening in their portal system is not precise. This is why the hepatologists with their cirrhotic patients, they do routine endoscopies. They track them because they know that the disease process evolves, and the problem is that you only get punctuation clinically that tells you something when they have a variceal hemorrhage, when they develop acute encephalopathy, or if they suddenly get ascites. And that happens infrequently. But until that happens, the disease is progressing. So if you've got a Child-Pugh A patient, I would say that getting a FibroScan in these patients is really good to reassure yourself that, yes, they're in a safe zone.
Yeah, because we do see a lot of times, when we start the surgery, patient looks fine, but it's actually, these guys who are doing the surgery, they're telling us, that the liver doesn't look okay, or so it's actually an intraoperative finding of cirrhosis rather than it being a preoperative finding.
Yeah. Well, I think that's the other problem that surgical imaging is brilliant, because basically by chance you find a lot that you wouldn't expect otherwise, but it's not perfect. And the slide I showed you, it was all stereotypical in terms of liver disease progression, and you had a hard knobbly liver. But actually, when I showed you the histology, that hard knobbly liver probably doesn't look like that when it's F4A. F4A is very, very minimal fibrosis. But these patients, you open them up, you can see it, but you can't see it on the CT scan that easily, or you can't see it on the ultrasound. So there is a bit of a disconnect. I think he's going to come and ask a question again.
Yeah. So it's more to kind of take advantage of the fact that we've got you here and you've got a huge experience of dealing with decompensated livers and transplants and post-hepatectomy in cirrhotic patients. So just want to take that opportunity of using your knowledge for my benefit here. So if we do these resections and we do get this post-hepatectomy liver failure, which don't recover as you would expect them, what are the tips, tricks of the trade that you would give us so that we can implement here as well? Because this is one of the things that I struggle with.
Yeah.
So I would like to learn from you.
Yeah. So, I mean, post-hepatectomy liver failure is like really tricky clinical entity to deal with. It's a massive subject in of itself. A lot of these patients, just with simple, good intensive care, they turn the corner after 2 or 3 days. So there's grades of PHLF, A, B, and C, and sort of A and B you can manage on the wards, and C, you basically need to be admitted to intensive care. But some of them, you may just need good fluid therapy to improve renal perfusion, and the patient, starts to get better. And although their bilirubin is still high, they can then be managed on the ward again. But I think what you're talking about is the patient that just escalates and escalates. And that's really difficult. So I think there's several key things. Nutrition is really important for these patients because they become hypercatabolic. Another really important thing for these patients, and again, enteral is preferred if you can establish enteral feed. And if you can't get NG feed, then try and place NJ feed. Beyond nutrition, in terms of the intensive care sides of things, I think limiting the portal flow is actually quite important, and potentially the vasopressor that you use may make a bit of a difference. So there's some weak evidence. It's observational. It's come out of our center, but it suggests that patients who are treated with terlipressin, they have better outcomes than, for example, if they have blood pressure support with noradrenaline. And the reason for that is because the terlipressin, it actually reduces the portal blood flow. You get less sinusoidal damage and less sinusoidal stretch. And that means that as long as you can maintain the perfusion of the liver without over-perfusing it, there's a chance for the liver to get back. The real key thing for post-hepatectomy liver failure, though, is to avoid sepsis. Because that slide I showed you with the risk factors for mortality in PHLF showed that cirrhosis had an odds ratio of like 55. The next one up there is odds ratio of 37, and is sepsis. So you have to be really vigilant, looking for infection and treating it really aggressively. So, I think beyond that, I think you all know how to treat sepsis. I'm not going to teach you how to suck eggs. But these are the things that you need to do. Concentrate on nutrition, avoid infection, and consider whether or not you can reduce portal flow with terlipressin. Thank you.
So thank you very much. So that concludes the talks of this session. We had one talk scheduled, Dr. Faraz, but in the interest of time, we'll just skip it and come to our final panel discussion. So if I can ask our panel to Dr. Faisal if they can join. Mansoor, if you can join the panel as well. So, and Dr. Khalid, if you can. Okay. So the topic of our panel discussion is intraoperative resuscitation, sorry, intraoperative cardiac arrest. Then do we need a separate set of guidelines? So I came across this topic. I think Faisal gave me the idea of doing a discussion on this. And when I researched this, so there's recently in 2023, the European Society of Anesthesiologists has given a set of guidelines for perioperative cardiac arrest. So there are a couple of interesting things that they've pointed out there. So I think I'll just start with Dr. Faisal Khan, if you can share your views regarding the need for these for such guidelines in the perioperative period.
It's working. So no. But before I comment, can we ask the audience what their thought is? How many of them wanted to have believe that there should be a separate guideline on the perioperative cardiac arrest? कितने लोगों की thought process है कि perioperative में? Okay, it's a number. People still want something.
So how many don't want separate guidelines? The ones with your hands down, you don't want separate guidelines, or you just didn't put your hands up?
Do you think we can't manage the intraoperative cardiac arrest with our knowledge of ACL? Do we need a separate guideline? That's the hope.
That's the main question of this panel discussion, that if somebody has a cardiac arrest intraoperatively, perioperatively, so can't we manage the cardiac arrest with our ACLS? Why we need a separate guidelines?
Do you think so?
Do you need a separate guideline?
Experts in dealing with a cardiac arrest on tables. And I think guidelines are made for fools who don't know what they're doing. So I'm not saying the physicians don't understand cardiac arrest, but their understanding of physiology is not as good as your critical care anesthetist. So I'll be very surprised if everybody wants separate guidelines for it. And I'll be worried about my patients after this. So
and that's why you're our favorite surgeon.
That's why I'm surprised as well. But before thinking about any separate guideline, we just need to know the burden of disease and what the difference between the perioperative period or without the perioperative period is, because this is not a very common entity, and of course when we talk about, there are three main factors are involved, the anesthesia, the disease or the patient itself, and the type of surgery, and of course the guideline usually being made to generalize the thing that the group of, it's a bunch of cohort and you need something separate for that. But the guideline, if we all see the ERC, the European Resuscitation Council, the AHA, they give a very broad understanding about, and all these things are usually based on the outcome, what we usually follow, the ROSC and the survival for discharge. And I believe that all these things are very much relevant, very much important, and all these interventions that have been done during the pericardiac arrest situation has its own value. And
few things are much important that they have been designed about the process of that. But I usually believe in any cardiac arrest, that three things are important: the prevention, and the process they being involved during the cardiac arrest, and the post cardiac event resuscitation as well. So where we are as an anesthesiologist or the perioperative physician, I believe, we all anesthesiologists are ACLS certified. They know their patients. They know the disease pattern of their patient, and they are lucky because they can easily predict the problem that can happen in the next few minutes, because they have all the monitorings, which usually not available outside the OR, but it is available inside the OR with a good team of people, and they can really help their patients. The only issue comes in, like if you go with the subspecialties, like, there would be the cardiac surgery or the hepatic one, because the physiology and the dynamics are bit different. So they may have some addition on that, but as a general feeling, my viewpoint is whatever we have, it's really very useful.
So my question will be, if someone is having a cardiac arrest in the OR versus in the ward, who will be getting the better chance to survival? Who will be getting the good care?
The cardiac arrest in OR is different from the cardiac arrest in general, which is happening in the wards, because these patients are already monitored.
Yes.
Firstly, they are intubated, and they have trained physicians already in the OR, and plus most of the causes are reversible. So they are either related to anesthesia, or they will be related to the surgery, or they might be related to the patient. So that's why that makes it different from the cardiac arrest happening otherwise.
And of course,
So if I may
That's
add,
why I think it makes the outcome also better in these patients.
so actually the interesting finding from those guidelines is actually the outcome is not better in perioperative patients. So perioperative patients who have cardiac arrest, they have got a mortality of more than 60%. And that's with all the monitoring being in place, with the trained personnel being at the bedside, having help in terms of having all the members who are required in ACLS quite in the vicinity of where the arrest has happened. So what Dr. Faisal pointed out regarding this specialty, actually the incidence, the quoted incidence is actually higher than what we think. We think of it as a very rare event. But if you look at cardiac surgery, the risk is about 1 in 40 patients. And in non-cardiac surgeries, it can approach as high as 1 in 300 to 400 patients.
So basically, I would like to ask you whether it's the incidence of cardiac arrest or it's the recovery from the cardiac arrest.
The incidence of cardiac arrest, but the mortality is more than 60% if you have a cardiac arrest while undergoing surgery.
So that is basically the question we need. We need a separate guideline for that or not.
So Mansoor, I was thinking about the sentinel events that we've had. In my experience, we'd have few patients who've had a cardiac arrest during surgery, and I think what the expectation is that having an anesthetist at the bedside who's trained for ACLS, having all that help support, it would be a better coordinated effort to resuscitate that patient. But I think just from my recall, it's never a planned activity, and it's almost as chaotic as anywhere else.
Yeah, I think that's counterintuitive, but true.
Mhm.
So, if you ask most hospital doctors that don't work in anesthesia, they'd probably have the perception that you gave at the beginning. But the reality is that you mentioned that in non-cardiac surgery, you're looking at an incidence of roughly 1 in 300 or 1 in 400. And earlier on, we heard about team working and the perceptions of team working as well. Well, you can't resuscitate a patient anywhere without really good team working. So first of all, team working is a really important factor. But the second thing is that at an incidence rate of 1 in 300 or 1 in 400, the people around you who are not anesthetists, one person is busy stuck inside the patient trying to do their surgery, but everybody else is running around for supplies, or they're an operating department assistant. They're not expecting a cardiac arrest. And so when it happens, it shocks them and it's total chaos. And although we're highly skilled and, you know, the people around us have more skills probably than many of the people in the rest of the hospital, it still pans out like chaos. I think the only way you can get around that is to have regular sort of sim training, so that it becomes something that's anticipated. And I think certainly in the West, cardiac surgery units, cardiac intensive care units, they have regular drills where they look at resuscitating, you know, open chest on the intensive care unit, where they simulate resuscitating patients after cardiac surgery. I think we shouldn't be surprised that we might need separate guidelines. We know that you need separate guidelines for children because they have a slightly different pathology. And we know that surgery is a very different animal to patients who are on the ward or in the community. So there's already separate guidelines for neurosurgery. There's guidelines for resuscitating patients in the prone position. It's completely obvious you need different guidelines for those that group of patients. And similarly, you know, cardiac surgery is very well established as having a different set of guidelines as well. So I think having a really well-trained set of individuals that can run normal ACLS for the majority of non-cardiac surgery probably will be okay. But I think it's absolutely clear that there are definitely areas where new guidelines in Pakistan or established guidelines elsewhere in specific theatre settings are needed.
So Dr. Faisal Jami, bringing you into the conversation, I think we've sort of become guideline trained sort of service people, that whenever we've got, you know, any sort of problem, we're looking at guidelines now, and, you know, and they've shown a lot of work. So would it, you know, help if we just come up with these guidelines, you know, like Mansoor says, that, you know, just if we've got separate guidelines, we just come up with them, and that can actually, when we've got a set of guidelines, then everyone can sort of get in motion whenever the unthinkable happens.
When we have been surrounded by many guidelines, we read it, but we do what we know at that moment. So guidelines, just, I think they are just there to help you, to facilitate, to think about. It can give you a framework, but in actual scenario, I think that your ACLS, if you are ACLS certified and you are trained anesthetists, you know your patients. So I mean, paperworking and giving a framework to the trainees to understand, pinpoint these subject. But I think in the clinical scenario, we know what we know and we do what the point which Dr. Mansoor has pointed out is really important, that because we are not anticipating a cardiac arrest very frequently, so our team, I think, don't prepare in that particular scenario very well to work out in a non-chaotic manner. And that happens, that chaos has been there. Many people are trying to lead the scenario, though we know that the anesthetist is the guiding and the captain of that ship. So guidelines can be brought up, but I think.
I mean, sorry, I was going to say, sorry to interrupt, Asad. I was going to say that the point of the guideline isn't that the patient arrests and you grab it and you say, let's go through it. I mean, even ACLS is a guideline. The guideline is there to tell you what you need to do. It's there to teach people who've never done it before, so that when it happens, then you run exactly as you're saying. You know what you're doing, and everybody knows what they're doing.
So, thank you for bringing up this topic. I want to start off by echoing kind of what you said. That guideline, we have to understand what guidelines are. They are the for the lowest common denominator, right? To set up basically a floor. Like I mentioned in my talk, variability in practice is the #1 reason for bad outcomes or adverse events happening. And it unfortunately often people, and I was looking for my surgical colleague and I can't find him, who said that we don't need guidelines and then walked out. The majority of people are not at apex institutions. They're not at Shaukat Khanum, they're not at Khan, they're not at these high-level institutions. So guideline, how do you guide other people? I'm going to give you 2 instances. And these are personal instances that I've been part of. I have been in codes where as a resident, during a cath, a patient went into AFib and then VFib and ventricular arrest. And it took, the call there was for anesthesia staff to come and intubate the patient. There's a regular cath. At that point, I was a trainee anesthesiologist. I went and intubated the patient. And then I looked up. Nobody was doing chest compressions. Why? Because all the cardiologists felt like they were in control of the situation. We just have to fix this problem. Everybody's focused around that. So in the OR, what you mentioned, the tasks are already predefined, and switching from one task to another is the key for these sort of resuscitation events. And often we don't do that. It's hard to switch, and that's why it's a separate set of guidelines are needed. That's why on the floors, we go suddenly from regular care to contingency care, which is what ACLS2 teaches, right? That's a contingency team that comes together in a certain situation and comes together. It's hard to make that switch. I'm going to give you another example of a colleague of mine and others who was undergoing a procedure in anesthesia, monitored by an anesthesiologist, continuous monitoring, and during that time, they became hypotensive. They had ventricular, some arrhythmias, and they were treated by the team over there, but they didn't recognize this was actually a cardiac arrest and not an arrhythmia. So this is where continuous monitoring, a lot of things to anesthesiologists, we might actually be, a little bit of information can be a bad thing. So in other situations where ACLS operates, right, where you go from no monitoring, sudden arrest, and then suddenly you go into guidelines. In anesthesia, we have continuous monitoring, and that can actually lead to a false sense of security. And as anesthesiologists, we often think, oh, it's hypotension. We will treat that. We give some, pressure is low, we give them uppers. The pressure is too high, we give them downers. The heart rate is too slow, we give them something to speed it up. It's too fast, we give. So we feel like we can control the situation. So often that gives a false sense of security. It might not to professors, people who have tons of experience, but we are not the ones providing care to 100% of the patients. We provide care, direct care to maybe 1%, 2%, 3% of the patients. So I 100% believe the guidelines are needed because the common denominator is not us, it's the masses.
So I have a slightly different opinion to offer. I think the first thing is that, do we agree that perioperative cardiac arrests are managed poorly or not? I believe they are. There are multiple factors that are fed into this poor outcome. These patients, 60% mortality, probably one of the things that accounting for this mortality is the patients themselves. These are unwell patients who undergo surgery and then they have a cardiac arrest. The problem does not lie per se in having guidelines or not having guidelines. I think that's a different question. The issue here is how do we deal with that situation once the situation arises? And I think that goes back to the original discussion that we were having in the previous session as well, that we need training. So the training must not be equated with having guidelines or not having guidelines. The issue lies elsewhere, which is we need to be trained that this patient or a patient may cardiac arrest in the operating theater. And then a fairly seamless teamwork that needs to go into to improve outcomes. Guidelines may not be the answer. It's ultimately at the end of the day, it's going to be ACLS guidelines.
Those patient groups who are really different and they require some extra interventions, AHA already highlighted those like the people who have a drowning, the people who have pregnant patients. So few groups of cohorts have already been identified that need an extra intervention, or few things need to be prevented during the intervention. But in terms of the OR setting per se, there are 3 or 4 important things which are really important that helps in improvement of the outcome. One is the end tidal. Second is the diastolic blood pressure, and few of the patients in the OR, they have arterial line as well. And the other thing would be the chest compressions and all these things. And as an anesthesiologist, we all have been trained. We all see all these 2 or few things very much regularly in the. So if we do these type of things with the monitoring, so I'm surprised that the outcome would be bad. Because as Faisal mentioned, in the chaotic situation, usually we forget to measure all these things. We forgot to see all these things. That is why, as Dr. Mansoor mentioned, the training is very much important, because in OR setup and all these things, we usually do not see these in a very routine way. And we do the training after every 2 years. And we forgot the thing after 6 months. That is why, the frequent mock drills really important, especially in those areas where the events numbers are really low. That is why, in AKU, we are doing the in situ mock codes on the simulators. We created the mock environment, and the teams, we call them as a routine rush call on the pages, and they come and they do the CPR on a clinical, on the clinical situations, created the clinical situations as per the HR defined. And we see the end result as well. But interestingly, I would tell you what is happening, because initially we thought that we'll do the surprise, codes, so the people might not be aware of it. But it's not very much difficult to do this, because if you are running a show in any unit, the head nurse or the others, they usually get aware and they explain the staff that tomorrow might be the mock code day. So, and they started to read all these things, what the algorithm is. But when they do actually, when you run the code, the problem remains same. So that is why, the algorithm read and all these things is really helpful. But what you do in an actual scenario, it's really, really much different. And that only comes with a good training. If you do the mock codes every month, and make sure that everyone who is involved in the patient care have been gone through this. So that's the only thing I believe that might help to mitigate, the risk, as well as the outcome would be better.
I agree with the need for constant training and constant repeating, but I'm in fact an advanced life support instructor, and I've seen experienced nurses and doctors, and very often junior doctors, come to the courses and they've read the manual and they know the algorithm. But when it comes to the practice on the mannequins, they're terrible. But after a couple of days practice on the course, they become much more proficient. Now, just because you need to practice and you need to be experienced, it doesn't take away from the fact that you need a guideline. The actual algorithm that we train on is a guideline. And so there can't be any doubt that you need to have a guideline. Otherwise, why don't we just get rid of ACLS? Let's just use our own skills, use our pharmacology, use our medical knowledge, medical school stuff. We should just lead it and we should just do it. It can't work like that. You need to have some framework by which you set everybody's standard, but then they have to train to that standard. Yeah. So I don't think there's any doubt that the training is absolutely key. There's no point with a guideline with no training, but you can't train without a guideline.
Hello. So my question to the panel is that since we're discussing perioperative arrest, so the ACLS and most of these guidelines, they describe the starting trigger for chest compressions as an absence of pulse, peripheral pulse or carotid pulse. But at certain occasions, we have an arterial line monitoring being done during the surgery. And if there is hemorrhage and the pressures are going down, the arterial line is also going to be showing, even if it's as low as 20 or 30 millimeter of mercury. So is there any guideline as to at what arterial pressure readings we can start chest compressions?
Go on. No, go ahead.
Okay,
I'm not aware of a specific number where they say that, but when the patient's monitored and it looks like they're losing consciousness, if I remember right from the manual, you can intervene at that point. So you don't have to wait for asystole. You don't have to wait for a flat arterial line trace. You can start when it's very obvious that the patient is about to arrest. And sometimes that's actually enough to prevent the arrest. Because you essentially you resume cardiac output when it's in a downward spiral. But I'm not aware of any specific number. I've never read it anywhere that you must intervene at 40 or 30 or something like that.
Basically, the recognition is also very important. But at the same time, when you're doing CPR, sometimes what happens that when you interrupt in between to see the rhythm, you're getting some kind of pressures. So if it's like systolic 40 or 50. But even then, we, on our personal experience or our personal opinion, we say, no, we should continue. So I think it's basically the scenario in which we are at that time, or the people around and the condition of the patient. For example, if a young patient is on the table, then probably you get, say, mean 50 will be okay for that patient. But for an old patient, you can say, no, it should be more than that, and we should continue with the CPR.
Hello, sir. Welcome to Peshawar. And I have a question related to understanding the difference of risk of cardiac arrest, perioperative and preoperative. If we look at other than OT factors, OR factors, and the patient factors, if we try to understand the reasons of increased risk factors, considering the insult factors are increased in per op. Insult like increased oxygen demand, surgical factors, the stress response of the body. So yes, wouldn't other than RTLS, wouldn't it be appropriate to have even higher protocols for such patients, even after they are being reverted from cardiac arrest, going back into the ward? So I would insist that wouldn't it be appropriate to have a higher standards for such patients, because they are having higher insults than just a patient in the ward. So
I completely agree. I think any patient that has a cardiac arrest intraoperatively, especially if it's in elective surgery where it's not anticipated, then really these patients need to be sent for recovery in high dependency or intensive care. And they don't have to be kept sedated necessarily for the first 24 or 48 hours. You can do a sedation hold at the end of surgery. And if neurologically the patient is okay, then potentially you could extubate if everything else is fine. But nonetheless, you need to monitor those patients. And many of these patients, you won't be able to extubate. You can't do the sedation hold. So these patients, you can't just send them back to the ward. It's not a small thing to have a cardiac arrest. It's a massive insult to the system. You need to be monitored.
So yes, I just want to, respond on Sami's question as well. That's the ultimate advantage you have, that you are monitoring your patient, and you have an arterial line, and you are seeing the numbers as well. And considering if someone who have systolic of 40, it means the diastolic would be around less than 10 or something. So you may need to decide about what you would like to do the early test, because now you have recognized it, and this is the early recognition. And then there is of course a role people are thinking about the pseudo PEA and the PEA. And the echo would be the best thing that helping you around that whether this is the true PE and the pseudo PE, and you can give something different doses of the medications. So it might work in that type of thing. There is people, that there is a role of perioperative echo less than 10 seconds. It's only the 3-second exam just to see the subxiphoid and find out the issue, and then it may help in the management to some extent, I believe.
I think it is also very important to actually, within the setup, For example, if someone is doing cardiac surgeries or someone is doing non-cardiac surgeries or ops, we have to look at the reason and we have to look at the data for like past 2 years and see what is the reason for the cardiac arrest. Because in my personal experience, patient gives some kind of sign for the cardiac arrest, and it is very important to recognize this signs. So we have to be very vigilant. For example, last month we are doing pacemaker in a kid, and the patient they were doing through the sternotomy, and patient after putting when they start dissecting it with the patient was continuously hypotensive, ready because we do giving epinephrine, norepinephrine, but there was the patient pressure. We thought this is because of bradycardia, because patient is going to have a pacemaker, but after some time we found out the patient actually developed pneumothorax. But they corrected the pneumothorax, patient became all right. Patient may go into cardiac arrest at that point in time. So it is very important that when patient is giving some kind of signs, then we need to see if patient has become hypotensive, or there is a change in rhythm or change in end-tidal CO2. We have to be vigilant and try to recognize the problem.
I agree with Dr. Khalid that usually in operation theaters, the patient was giving you time, some kind of information, and you were already managing on those lines, giving vasopressors, giving fluids. Very few patients who have sudden cardiac arrest intraoperatively. These patients usually are first become hypotensive or bradycardic or some kind of, but very few patients who, how many of us have seen a lot of pulmonary embolism in intraoperative setting? Very few. So yes, they are giving and you are already managing them, but sometimes now if it's bleeding is going on, you can't do anything. You just have to restore the volume, give vasopressors and let the surgeon do the other things. Okay.
Yeah.
This is Dr. Emil Bungish. I am just invited by my nephew, Masoor Bungish. And I've been a consultant anesthesiologist in Denmark, and I've been working there for 38 years. I've just taken my pension. I couldn't help myself to come with a comment. I had been working in one of the biggest hospitals in Denmark, and I remember that when I started taking charge of it, my boss told me that they do die when they come there. And it was, in fact, the major surgery was the abdominal aorta rupture. I was lucky enough that they didn't die in when I was in charge, but I have seen a couple of deaths intraoperative, and but it's a very extreme, rare incidence in Denmark, and they don't have any separate guides for resuscitation at the operation theater. On the other hand, they do have guide for every second year. You have to take a course which is in fact checked by your hospital, and if you don't take it, then probably they will it will result in some reprimands. The major thing which I have experienced is anaphylaxia due to different drugs. And in Pakistan, I can expect that it is much more common than probably perioperative deaths, because the patients they are not acquainted with their own side effects of different drugs. Have you any experience in that, and how to treat them when they are probably suffering from severe anaphylaxia?
Not death, but I think I came across with a case when I was a resident, that a patient who developed severe anaphylaxis post-atracurium. So the patient has been given an atracurium during the induction process, and she had started rash, spasm, and then she had a very low blood pressure, and she had arrest as well. And she was responding with the resuscitation process. So this is one of the things I remember, but not as a death.
I've seen one case with the test dose of the antibiotic, and suppose yes, and the patient becomes severely hypotensive and bradycardic. But again, the key was that the patient was having arterial line. We monitor the arterial line, we monitor the internal CO for the heart rate. So we immediately start the resuscitation. And fortunately, the patient didn't go into the cardiac arrest. We changed the antibiotic. That's
And the one other area which we are now, we should be aware and we should have a knowledge is as we are doing much and more regional anesthesia. So although there is again very less incidence of local anesthetic systemic toxicity last, but we should also know that the lipid emulsion should be available in all those setups where regional anesthesia is now being commonly practiced, because if there is a last happened, then the only thing which can treat this local anesthetic systemic toxicity. So that's why there is a separate kind of guidance from the regional anesthesia UK and the other regional anesthesia societies in the treatment of local anesthetic systemic toxicity.
So with that comment, we'll come to the closing of our session. So Mansoor, if you can carry us forward, what should be the next, what is the way forward in terms of these guidelines? Okay.
I think I can't remember which speaker it was, but somebody said that we don't have as much time in our lives to make the mistakes ourselves and learn from them. And we should learn from the mistakes that other people have already experienced. And I would say that I think the safety culture in anesthesia is actually a relatively emerging phenomenon, even in the West. But they are pioneering it. And my suggestion would be that just like we have taken on ACLS, which is a Western algorithm, we should probably follow their lead. So that definitely for specific surgeries, prone position neurosurgery, we should look to their guidelines. Cardiac surgery, we should look to their guidelines. It was actually news to me regarding the European announcement from earlier on in this year or last year. So I'll have to look that up myself, but we should probably follow those. And we should probably try and implement those in our departments and make sure that these are regularly drilled into not just the doctors and the nurses, but all members of the theatre team staff. That's my advice.
I think I would like to add this, that as we are having the mock drills in other parts of the hospital, I don't think so we have any mock drills going intraoperative, any in the OR. So the one of the way forward is to start at least a mock drill in 6 months. And because our anesthetic and surgical technicians, they are not very used to do cardiac compressions. We do courses, we practice on mannequin, we passed our ACLS, and that's it. So they are not used to it, how to manage a cardiac arrest in a better way, not in a chaotic situation. So I think the way forward is starting mock drills for operating room staff.
Okay, thank you very much. So with these comments, we come to the end of our sessions. Thank you all. Thank you all for attending. Hope you enjoy the rest of the symposium and enjoy your stay in Peshawar. Thank you very much.